Okay. It's 8 sharp. I think we'll start in time,
Yes,
although
sir.
many times we end late.
Yes, yes.
Often complained by none other than Velarvin. So let's start in time. Yeah, good evening, friends. Welcome you all to this another meeting of Inform. And this time we have chosen a topic on infection control in nephrology. So this might sound slightly unlike a topic for interventional nephrology uh, interested people, and it may sound superficially slightly boring also. So I was keen that it should made sound interesting so that because it's a very important thing, and just now before the start of the meet, Vel Aravind and I were discussing the importance of infection. See, when we come across a newer field like interventional nephrology, you get to see new things. Then you start learning new things. Then you start doing new things. Then the ultimately the results when the outcome out of your effort comes out, then you really enjoy and you cherish. But there will be occasions when all your pleasure and enthusiasm will be spooked off by issues, and one major issue would be infection, and which is potentially a preventable area. So unless we concentrate on that, it might look very trivial, but it can ultimately dampen the interests of interventional nephrologists, especially the new ones who are entering it, because after doing a difficult AV fistula, at the end of 2 3 weeks, if you develop an infected anastomosis and it bursts and you lose the patient, it is very hard to imagine this boy coming back into interventions again. So it is very nice that this topic was thought, and this was envisaged by Girish himself. And so I'm happy that a good number have joined. I wish more people will join and take lessons from here on. And each one of us seniors would have, you know, uh, experiences where uh, infection caused was the a spoil sport in the whole process. So with this introduction, I ask Vineet to introduce the faculty and chairpersons. And today we have senior faculties as chairpersons today, and Vale has joined after a long time, and we have guests from overseas, and I welcome them all. And Vineet will introduce the speakers and start the meeting. Vineet, yes.
Uh, Good evening, ladies and gentlemen. It's a pleasure to introduce the distinguished chairpersons and the speakers for today's session. Next slide, sir. Dr. Vail Arvind needs no introduction. He is the leading nephrosurgeon of the country and the world. And in the field of intervention nephrology, he has been a landmark. And the level of interventions he is doing are all much higher than what the surgeons do. And we all know him popularly as the person who is mainly running the popular kidney transplant group, and he is presently working as the chief transplant and intervention nephrology at Pineapple Dialysis Center, Trichy. And so welcome, sir. Next slide, sir. Dr. Raj Kanwar Yadav is the additional professor, Department of Nephrology from AIMS, Delhi. He is one of the leading intervention nephrologists from AIMS, and we all trained under him and learned our basic interventions from Sir only. He had his initial experience at PGIMS Rohtak. After that, he has been working in AIMS. Sir has got numerous publications and key research work to his credit, and multiple awards and distinctions like best poster awards and best paper awards, and also very key. He has often included in one of the in various key decision making bodies of the country. Welcome, sir. Next slide. So we are very thankful to Dr. Neelam Sachdeva ma'am for joining us. She is the senior consultant microbiologist and head of infection prevention at Rajiv Gandhi Cancer Hospital in New Delhi. And being a microbiologist, she's the apt person to guide us and take us through this session. And she trained and did her MD medical microbiology from MGIMS Wardha. After that, she has got a wide experience in the field of infection control and microbiology, and did extensive training and studies at numerous centers from all over the world, including her observership in infectious disease from Cincinnati, USA, and has got a wide experience in different hospitals, including Jaipur Golden Hospital, and since 2011 has been working in this present center. And she has got numerous publications and research works to her credit, more than 100 oral papers and presentations. And she also has been deeply involved in various hospital epidemiology and infection control aspects in the country and abroad. Thank you for joining us, ma'am. Next slide. So Dr. Girish Reddy, who is the assistant professor from INU Bangalore, needs no introduction. So he's a dear friend and is a very well-known face of intervention nephrology from our country, and is one of the leading intervention nephrologists from India. And we can call him the face of interventions from India. And he has numerous distinctions in the field of intervention nephrology, including being one of the youngest Pasdin awardees of India, and has been also recognized and solicited as the Achiever in Nephrology Award by the Lieutenant Governor of one of the states. And he has more than 1,500 to 2,000 endovascular procedures to his credit. And he is also keenly involved in various research activities and publications with regards to intervention nephrology and vascular access. Welcome, Girish, and thank you for drafting this program. So we have one of our two young budding intervention nephrologists from Girish team in INU Bangalore, who are both working as intervention nephrology fellows, and it is their maiden appearance or maiden presentation in this forum. So Dr. Cherin Champanur is from Mumbai, and after doing his DNB from Coimbatore, he had a short stint working in Chennai and then in Mumbai, and thereafter he joined this center as a fellow in interventions. And he is an active researcher, has got multiple publications. And welcome and great to have you here, Cherin. Dr. Sahil Arora is from Delhi, and he is a graduate of JIPMER, and also has got numerous academic qualifications like MNMS, ESC NEF, and he also worked in Delhi in the ESI hospital for some time, was also in Safdarjung hospital working there, and a keen researcher, has numerous case reports, publications to his credit, and he is presently working as the fellow of intervention nephrology in INU. So welcome, Dr. Girish and Dr. Sahil. And with this, I request the speakers. So how we go about is that we have our speakers, Dr. Cherry and Dr. Sahil, who will be briefly taking us through the talk. And we will request Girish to moderate and give his expert comments in between, and we'll have involvement of chairpersons. So Dr. Cherry, you can share your slides.
Yeah, sure, sir. Share your slides. And as he's sharing his slides, I need to make a small announcement here. I don't know, many of you may not be aware that there is a society called Asia Pacific Society for Dialysis Access. This was started in Korea, and it involves all the southeastern countries, including New Zealand, Australia, Japan, China, Taiwan, etc. And every year meetings are held, and meetings are actually of very good quality, but the membership and the society itself is not very big. And now this term, Dr. Sampath took over as the president of the society, you know that. And now recently I've been made the secretary general of the society. And so with this responsibilities, I think we have a great opportunity in putting our footmark in this regional society and make our presence felt and participate in a bigger way. Actually, this year, the annual meet is going to be in Singapore. Dr. Tan is, and many of you would be familiar with him. He is organizing in Singapore. He is doing it in a big way. He has combined it to their national meet, and it is nearly a 2 full-day program for interventional nephrology. And he is a high-quality person, you all know. And I would, spread the news and give the details of the conference. And to become a member of the society, it is a life membership. It is only $100, and I'll make all this thing announced to you in proper channels. I think just I'll stop here about this introduction about APSDA. And right now, Dr. Jasuja and there are some more people who are in the executive committee. We plan to involve more of our friends and make our presence felt. Thank you.
Yeah. So Vineet, we are really honored to have Neelam Sachdeva madam joining us. She brings an important perspective, being the infection control head. I think that's very important for all of us to have her giving the opening remarks. May we request Neelam madam to give her opening remarks before we start this session. Neelam ma'am.
Ma'am, you have to unmute yourself.
Yeah. Could you unmute yourself, madam? Okay.
Okay,
Yeah, you can hear me.
yeah. Can you hear me now?
Yes, ma'am.
Yeah.
Yes.
So, okay. Good evening, everyone. See, basically, what I want to tell you is like you people are much more educated than me. You know better about your field, but then something important which I really want to tell you is that whatever good job we may do, but then if infection is there, then things are bad. And we all don't like all these things. So, what we need to play a role, an important part is like strict asepsis, which you all have to follow. Another is maintenance of the cannula is an important part which we have to do it, or whatever the AV fistula which we are making it. So if we don't maintain and if there is an infection, so one is huge amount of money which the patient has to pay. And what we have seen of late is that superbugs are becoming very common. So Klebsiella is on the top, followed by that is E. coli, and then pseudomonas is there. Acinetobacter once upon a time was there, but now it has become a good baby. So you normally don't find it anymore. So it is basically Klebsiella, which is a dreadful organism nowadays, and majority carbapenem resistant. So once the patient gets infected with a carbapenem resistant organism, so obviously you need to give either colistin or polymyxin B along with meropenem combination, which usually works better. Or if it is NDM, all this is not going to work, and you have to go ahead with the synergy testing and go ahead with the zitronam and ceftazidime avibactam. But thing is like that is going to delay the treatment part. So that is one thing. Unnecessarily delay is and money. Both the things are there which are very important. So we think we are perfect because we have either made the fistula or we have put the cannula. But if we don't maintain and patient gets infected, then obviously it's bad. So maintenance is something very important where we really need to focus on. Otherwise, patient will have a tough time. And whatever good job we may do, but infection is going to take away everything and is going to give you a bad name. So it's something important. It looks very small, but it's a big thing and everybody has to pay for it. Not only the patient, but the doctors. And with era of, like customers, the care and all coming into picture, I think, like it's something where we really need to focus on. So there are few things where we really need to focus on is when we make an entry, when we are giving either when we start our dialysis or when we are giving any drugs and we are using all those cannulas and all. So what we exactly need to do is the entry point has to be clean because biofilms are very common and these bacteria are smart enough in the sense like when they are together, they don't need food more. Metabolic rate is low. But then even if one resistant bacteria is there, they very fastly, they share their R gene, making everyone resistant over there. So what we need is, we need to remember one thing that 30 seconds are important when we want to kill bacteria. 15 seconds rub and 15 seconds wait. So that's 30 seconds have to spend before you really make an entry into an any line. If you don't do that, we are actually taking the bacteria along with. And then another thing, like what exactly to be used. we were very happy to use alcohol, but it is no more a part because alcohol works and kills only gram-positive bacteria. We carried out a study in our hospital and we saw, we even made the concentration to 80%, 90%, and even 100%, and increased the time of alcohol from 30 seconds to 45 and 60 seconds. So 100% alcohol, 60 seconds never worked. So finally, it has to be added with some adjuvant. And what we saw that chlorhexidine is always the base. So alcohol and chlorhexidine kills gram-positive, gram-negative, and fungus, which we usually found as biofilm at the entrance point, which we call it as a hub. So that is an important thing which we need to do it before we actually we use that as a line whenever we are either giving medication or we start the dialysis. So that's what I have to say.
So Cherin, I think you can start.
Yeah, we can start with the presentations and then,
Cherin?
I mean,
Yeah, sure, sir. Is my screen visible?
Yeah.
Try to make it full screen.
The full screen mode. Yeah.
Yeah.
Good evening to all my seniors and respected nephrologists and all the other doctors present. So we are talking about a very basic but a very, very important thing in all across all the medical faculties and especially nephrology. We have a unique set of patients when we deal with who are immunocompromised, whether they are on dialysis or post-transplant. And there are many reasons for that. One is the uremia-induced immune dysfunction, frequent vascular or peritoneal access, recurrent hospital visits, and comorbidities. Very sad to say, but Indian Society of Nephrology had a study conducted and it showed as infection as the second leading cause of death in dialysis patients after cardiovascular disease. And even the CRBSI rates in our units can reach up to 3.5 to 5.5 per 1,000 catheter days. There are unique procedural vulnerabilities in our faculty. So when we deal with different procedures like hemodialysis, there's repeated cannulations, catheter use, reuse of dialyzers. And if there is not adequate training among the technicians, the inadequate hand hygiene while dealing with patients. Similarly, in peritoneal dialysis, exit site or tunnel infections and peritonitis, a lot of vascular procedures like AVF procedures where we do frequent Doppler and interventions. And because of repeated cannulations, repeated buttonholing, there could be potential skin breakdown, which is definitely a factor for landing infections. And one of the most important procedures are the CVC insertions, where high CRBSI rates are there. You need a sterile technique and proper exit site care. And even our procedures of renal biopsy, where the probe contamination can happen, or we are not preparing the skin area properly. In such cases, we have a lot of infections. So the current armamentarium which we have are povidone-iodine, chlorhexidine, and alcohol, and each have their own gaps. For example, like povidone-iodine, they do not have any residual residual effect post evaporation. They're easily inactivated by blood, pus, or any other organic matter. They cause a lot of skin staining, and iodine sensitivity has been reported. Chlorhexidine, as ma'am just told, there are a lot of resistance among the gram-negative bacteria, especially Klebsiella, pseudomonas, and enterobacter. They can also damage the plastics, and anaphylaxis risk, although rare, are documented. In case of alcohol, again, it evaporates quickly, so there is no residual protection. It's not effective against spores or some fungi, and high flammability risk in ORs. Across India, we do not have very set protocols. We usually have empirical practices which dominate, and no centralized guidelines for the residual antisepsis in nephrology. Sterile ultrasound gel, I don't think we have in a lot of centers. Very few centers must be using sterile ultrasound gel. And they're often substituted by the unsterile coupling gel or saline or alcohol rubs. India is a global epicenter for antimicrobial resistance. Chlorhexidine resistance is increasingly reported, especially among gram-negative organisms. CRBSI causing pathogens in India show high resistance to ceftriaxone, piperacillin, tazobactam, and even colistin in some cases. And fungemia due to Candida auris is also on the rise. So what constitutes an ideal biocompatible solution or a long-acting broad-spectrum. So it should offer residual protection. It should cover the entire spectrum of microbials. It should be non-toxic and skin-safe. Be device-friendly. It should penetrate biofilms and function well in real-world nephrology settings. So why conventional platforms fail? So I explained earlier also, povidone-iodine does not have a residual effect. It is inactivated by organic matter. It's cytotoxic to human fibroblasts and keratinocytes. It causes discoloration, staining, and can have allergic reactions. Chlorhexidine, very selective spectrum and emerging resistance. Toxicity in mucosal areas, anaphylaxis risk is there, and alcohol-based chlorhexidine degrades the plastic. Spirit again, because it evaporates very easily, no residual kill, and it's ineffective against fungi and viruses and has flammability risk. So when we look at the clinical implications, for example, in our procedures like AVF Doppler or needling, chlorhexidine or alcohol, it evaporates fast. And what does the outcome translate into? That skin flora regrowth within hours. Tunnel catheter insertion, again, we have chlorhexidine resistance and catheter incompatibility. Despite the protocol adherence, we still have CRBSI. PD exit site care, povidone irritates and chlorhexidine stings. Fungal colonization occurs because of it. In case of renal biopsy, unsterile gel is a common. Usually use. I've seen practices where we use gloves to cover the probe, and there is leakage of the ultrasound gel, and it causes skin contamination. Transplant ICU, definitely a big challenge. Immunosuppression plus poor residual kill. A lot of opportunistic infections flourish, and the outcomes are bad. So what do we have in the new upcoming thing called the SQ53? It has residual action. It is broad spectrum. It has good biofilm penetration, skin compatibility. It can be used in mucosal surfaces and is compatible with devices. So the workhorse molecule, which we know as polyhexamethylene biguanide, molecular weight is around 2 to 6 kilodalton. Mechanism of action, it binds to negatively charged phospholipids in microbial membranes and disrupts the integrity, causing cell lysis. It has DNA binding activity, thus interfering with replication. It penetrates the EPS layer of biofilms and active against the entire spectrum, gram-positive, gram-negative fungi and envelope viruses. A residual kill, it's retained in the stratum corneum for up to 6 to 12 hours and creates a microbicidal memory on the skin. It has a proprietary film-forming agent that binds PHMB to skin without occlusion. It prevents the early evaporation, unlike alcohol or chlorhexidine, and creates a breathable, semi-permeable protective shield. Humectants and skin pH stabilizers. So it has glycerin-like agents to retain the skin hydration. The pH is stabilized between 5.5 to 6.5, which is ideal for the skin flora, and minimizes irritation, improves compliance in chronic use scenarios. Aqueous, it is an alcohol-free architecture, so no ethanol, isopropyl alcohol or iodine, no burning, flammability or discoloration or cytotoxicity, and it's safe to use in almost all situations. So when we have the definitive comparison, it definitely performs well in terms of residual kill, biofilm penetration, or microbial spectrum. It does not have any cytotoxicity, and it's device compatible. Skin tolerance is excellent. Use with mucosal surface is good and does not have any flammability issue. So in clinical applications, where across the nephrology spectrum, where can we use it? So before cannulation or catheter insertions, the use case like temporary or tunnel CVCs, femoral or subclavian or jugular accesses, PICC line placement. The problem is the skin flora. They migrate into the tract during insertion. Chlorhexidine and alcohol evaporate rapidly, and risk worsens in diabetic and malnourished ESRD patients. The SQ53 forms a bioactive shield during and after the procedure. A residual PHMB prevents recolonization and tunneling infections, and it is compatible with sterile dressings and CVC hubs. In AVF evaluation procedures like the Dopplers or cannulation, fistuloplasty, we have, the use cases where we use a Doppler for checking the AVF flow or the AVF situation. recanalization or angioplasty of the dysfunctional fistulas, and repeated needling in difficult veins. The problem is the ultrasound gel is often non-sterile. Even if when we cover with probe, there can be situations where there is leak of the non-sterile gel, where my colleague will be presenting later, how it possesses a contamination risk. And chlorhexidine causes skin breakdown near the needling sites. SQ53, we can use it beneath or around the sterile ultrasound gel. It offers a persistent asepsis before, during, and after probe contact. Skin safe for repeated daily application and no disruption of acoustic coupling. PD catheter, another case where chronic PD patients with daily dressing needs, exit site infections are major cause of peritonitis. And these problems, usually we use povidone-iodine, which causes irritant or delays healing. And chlorhexidine causes stinging, not approved for mucosal or proximal genitalia. And there is fungal overgrowth from repeated skin disruption. So SQ53 offers the advantages in all this situation is gentle, non-staining, and fungistatic properties it has. Residual kill reduces the bacterial and fungal biofilm colonization and prevents candida and corynebacterium overgrowth. Number of critical care settings, immunosuppressed transplant recipients, ICU-bound AKI patients with catheters, biopsy wounds, CKD patients in daycare procedures or Doppler centers. The problem is the high nosocomial exposure, poor skin defense and broad-spectrum pathogen challenge, and device cross-contamination risk. Since SQ53 has an entire microbial spectrum, antiviral, antifungal, and biofilm active spectrum, it does not interact with adhesives or dialysis machine parts, and it's safe for multiple body areas. So where can we use all this? So suppose in case of catheter insertion, pre and post procedure, and it prevents CRBSI and skin recolonization. In cases of AVF Doppler, before probe and after cleaning. In PD exit site, daily dressing we can use. In post-fistuloplasty or on the suture area if we are creating AVFs, or when we have a surgical thrombectomy, in any case where we are opening the AVFs in such areas. ICU or transplant settings, localized skin protection at that time we can use. So it replaces a vulnerable immunity. So there are two important studies which not yet published. They have the evidence now and they are soon going to be published. So the Cleveland Clinic study had around 180 patients who were undergoing AVF interventions and catheter placement. And what they found was with SQ53, the infection rate was as low as 0.5% compared to 6.1% with the standard antiseptics. Less than 2% had discomfort compared to 18.3% with the alternatives, and 88% had negative SWAT 12 hours post-op with SQ53. Their conclusions determine that SQ53 demonstrated superior skin tolerance and significantly reduced residual microbial colonization compared to legacy agents. Its adoption could improve safety in dialysis access and transplant procedures. Another study from India was the Apollo Hospital study, where they had 250 patients involved in CVC insertions, AVF interventions, or PD care. The CRBSI rate was around 0.4% when compared to the 2.9% with the standard antiseptics. And 0.8% had skin site reactions. Patient reported, compared to 9.2% with the alternatives. And need for redressing, less than 12% patients had, even after 24 hours with the SQ53. With regards to closing remarks, I would like to say that cross-continental validation from US academic rigor to Indian real-world diversity, it demonstrated residual protection, biofilm suppression, and skin safety. It reduces infection, improves patient comfort, and lowers procedural complexity. These were the references used.
Thank you, Dr. Cherin, for the wonderful presentation about this new molecule. I would request comments from the chairpersons, Dr. Ved Arvind sir, Dr. R.K. Yadav sir, and Anilam ma'am.
Sharon, can you unshare the slides so that we can?
Yeah, sure.
Vinay, that's very nice. Actually, this new kind of gel we are going to use. I think, as he said, it's a device friendly because skin is a very solid immune organ itself. It's a physical barrier. chemical barrier, because the skin maintains 4.5 to 5.6 pH, and this gel is maintains stabilize that kind of a pH. So I think it seems to be, because it's breaking all negative aspects of legacy agents, what Charan was telling. So probably we are looking forward to use in a clinical practice and find out the results. But whatever said and done, and actually one of my surgical boss used to tell that every touch is very important. From touch to the final stitch, every move matters. So as a physician, we do have some kind of surgical application everyday life, putting a nick on the central line insertion and PD catheter, everything. So we should adopt first a very good aseptic measures rather than inviting trouble later. So that cannot be overemphasized. As Madam initially said, at least the initial 30 seconds waiting time is essential to act at least the legacy agents, and at least which are the right now we are available at our hands. And I think alcohol-based solutions not no more useful. It is negative results. And what we have right now is the alcohol-based CHG, chlorhexidine gluconate. That's what the thing is. And in Apollo Hospital, where I practice, where we are using AHT 3000, that is alcohol-based chlorhexidine. That is 3000 is the formula name. So I think we are looking forward to use this gel. I have my own doubt. He said in his presentation that this gel can be applied around the coupling agent or beneath. That's what the little I could not comprehend that point. Otherwise,
Yeah. So basically, this SQ53 is a biodefense platform, sir. So
Okay.
it is delivered in various forms. So it can be used as a liquid, as a wipe, or as a gel, or as an ointment. So in ultrasound settings, what we could do is we clean the probe with SQ53, we clean the skin with SQ53, and then we proceed with the regular sterile ultrasound gel. So that's how we ensure complete asepsis when we do the procedure. So it forms a nice 360-degree platform for ensuring a safe imaging procedures, sir.
Very interesting.
Any comments, sir? RK Yadav, sir?
Sir, very good presentation. I have few questions.
Yes.
One, you have compared both AVF plus central line. Is there a comparison between central lines? Because AVF, although they have less infection rate. Second is, what is about cost? It is costly or at the same cost?
Yeah. So, sir, the Apollo study, we have compared the incidence of catheter sepsis with the SQ53 and with the conventional alcohol-based and the betadine-based formulations. So there was almost the standard operating procedure was the same for all the patients. Like one set of patients received SQ53, one set of patients received alcohol and betadine. So the incidence of catheter sepsis when we compared is almost like 16 times. The incidence of catheter infection came down by 16 times when compared to the standard things. So definitely there is a clear comparison between betadine and alcohol-based formulations in Indian population. So the incidence of sepsis is very, very reduced, sir.
I have one
Second
question.
is the cost.
Yes, cost. Okay, sir. Cost, I think probably this is Indian manufactured. So I think cost will be definitely comparable to the regular formulation, sir. Maybe because of the 24-hour residual activity, they might be little expensive, but I think with all the volumes what we have, I think the cost should be almost comparable to the regular antiseptic solutions.
Is it available commercially, Girish?
Yes. So I think
What-
recently I came across, it's called as Darbx. Darbx is the trade name for this SQ53 solution. So already our colleague transplant surgeons are using it. They're using in multi-organ transplants. In fact, they only use in certain hospital settings Darbx, and Darbx is available across the country, Vineet. So I think that's the trade name as far as I know.
Neelam ma'am, request your comments. And then
Yeah,
come
I just wanted to know for how long this is going to like work, and the residual activity, like how much is the time exactly for this?
Yeah. So I think I was fortunate to look at their literature, madam, what they have presented on SQ53. So recently, I think a month back, they have done the testing in one of the world's reputed lab, and the residual action after using this antiseptic formulation lasted for 24 hours. So that's the data we have, and they have tested against all the bugs we have mentioned. So Klebsiella, pseudomonas, viral fungi, and also they have tested against acinetobacter, because we specifically wanted to look at acinetobacter, because of late we have been seeing some acinetobacter infections as well. So this biodefense seems to be working against all the pathogens, which are the most common causes of challenges in our clinical setting, and it is more than 24 hours. The residual surface activity is more than 24 hours, madam. That's what the result also says.
So any contact time, like you have to apply for this
Same,
much
madam.
time and
So
then
what we tested is what they have tested is the protocol that was followed was the same protocol like what we follow as you suggested, like 15-minute scrub and 15-minute wait. So with the same protocol, the residual surface activity was more than 24 hours.
24 hours. You mean to say.
Yeah.
Okay. I mean, if it comes out and everything is all good, so it'll work because
Yes,
I
madam.
mean, this is one of the criteria, but there are a lot of
Absolutely.
other things when it comes to infection.
Yes.
So obviously, it's skill of inserter is one. The
Yes.
type of like vein you're choosing, whatever, like
Yes.
subclavian or internal tubular
Yes.
model, so that is going to act. Another
Yes,
is skin antisepsis, definitely we talk about all
yeah.
this, and then time of contact. And obviously, hand hygiene always plays an important role. Without that,
Absolutely,
I
madam.
mean,
I think
failure.
the way we could really test it is because it's available as a platform. Like it should be used in all the kind of things, as a soap, as a pre-operative and post-operative liquid, and after the post-procedural ointment as well. So with all the formulations, if we can create a comprehensive bundle of biodefense and we test it, I think that would be the real amazing thing. Because what I believe is, if you combine with alcohol or betadine in between the whole cycle, then we will be unable to comment like which is causing the real action. So I think if we use this as a bundle, right from the soap of SQ53 to the ointment of SQ53, I think it would be a comprehensive solution and probably will have better outcomes as well, madam.
I think that works because it'll
Yeah,
be more of, like only this is doing this business. That's all.
exactly.
If
Yeah,
alcohol and chlorhexidine is used in
yes,
between, definitely you don't know whether it is your new product or it's the tested products which are
because then
really
it
working
becomes a
fine. Yeah.
compounding and it opens a lot of debate.
Yeah.
Like, we can argue that no, this is alcohol choice which is helping us, or this is the betadine which is helping us. So rather than that, in an ideal world, I would do the entire platform with SQ53 and see what are the outcomes.
Yeah. Starting from swaps to hand rubs to everything.
Absolutely, madam.
So
Absolutely.
that'll
So
be a good.
since it is deliverable in all the platforms, I think it definitely calls for a choice that we use all the platforms and then deliver it.
Okay.
Yeah.
Suresh, any comments from your end, sir? Suresh, sir? Any comments from your end, sir?
Oh, sorry. Yeah, I don't have any specific comments because unfortunately my part of the infection is very, very less. I'm totally an interventional guy. I don't do anything other than intervention, but from my procedures, I've not had much infections because we follow the usual protocol. And regarding the ultrasound, that's a good thing. Ultrasound, what we do is we have, of course, I think you also do the same thing. We have in a pack, it comes with a sterile gel. There is a sleeve
Yes,
as well.
yes,
Yeah, so we use that. And
in the US, we were using the packs.
yeah,
we used to have a probe cover. We used to have a sterile
probe cover and
ultrasound gel.
everything.
So everything
And
used to
gel
come
and
in a pack. So
right.
after coming back from US, I have struggled for almost 6 to 7 years. It was big cultural shock for me not to find sterile ultrasound gel and probe cover. So yeah, that mitigates a lot of our issues. Yes, sir.
So the ultrasound problem infection is totally I've not seen because I do lots of kidney biopsies and all that.
Yeah.
So that makes a difference. If you have a sterile sleeve and the sterile thing, it makes a big difference.
Yes.
Yeah. But this SQ3 is really good because it takes away all those problems. and
Yes,
you can totally eliminate fluorexidine.
yeah.
And even dialysis centers where they have to poke many times, if you ask them to wash, because here, when many centers, what we do is we'll make the patients wash their hand before we
Yeah.
put them on the chair, and then you apply the thing. So I think if you use a soap, it'll be a good thing.
Absolutely, sir. I think it should be a comprehensive bundle to deliver. Yeah.
Girish, Girish, and this is the pouch you sent to me for usage.
Oh, yes, sir. Yes, sir. I really loved it because it just reminded me of my US days, Thankfully, now we have the entire kit available.
Just my worry is, as you said, that you are going to get the entire spectrum, like soap to solution, everything, right?
Yeah.
So right now you have only this kind of gel. This comes in a different, this is a small pouch. I think sometimes we use, we feel this is so redundant, excess actually inside the pouch. We use it small amount. Can we put it aside and use it again? And
no, sir, I think one way of effectively utilizing it is because we are absolutely a penny sensitive healthcare ecosystem. And this is very, very valid point what you have made, that, what we would do is open up the sterile pouch, use the sterile ultrasound gel for the procedure. Once you are done, then the residual gel could be used as the regular gel. You can put it in the regular thing, so you don't waste. You are achieving both the goals at the same time. You're using a sterile ultrasound gel, and for the regular intact skin procedures, I think we can use the unused part of it.
Okay. So what I do, I use a little bit for the probe. I'll rest. I just wipe this the gel with the entire card of the probe.
Yeah. Yes,
so
sir.
make it
Yes.
more sterile, right?
Yeah, I think Sahil will enlighten us more in his next presentation. Sahil?
Girish, there is a question in the chat box that about SQ53. Is the infection rate similar or lesser than the alternatives? That means they mean alcohol or
the two
fluorescent.
studies, Cleveland Clinic trial, they have studied on the PICC lines, they have studied on the TPN catheters, and Cherin has already presented. There, the infection rate they have studied was almost like, if I correctly remember, 57 to 80% lesser when compared to the standard alcohol and chlorhexidine-based regimens. In Apollo study, thankfully, I was part of that Apollo study. As I told you, the infection rate significantly goes down. It's almost like 16 times. It has come down 16 times when compared to the standard regimen. So the infection is definitely less when we use this platform.
And they have also asked some important details like the p-value in that Apollo hospital study.
I think
Cherin, if you can
that
just
entire study is available, and the p-value was very significant. In fact,
Cherin, if you can just share the article here, so we all can go through that and have a look. And
sure. Actually,
Vineet,
we had presented this in last year ISN in Kolkata. This was an oral presentation. Also in Avatar, this has won the best paper award, SQ53 presentation. I think I'll share that with you guys. Yeah.
And there's a comment that using one packet of ultrasound gel has about the same carbon impact as charging a smartphone 60 to 100 times or driving a small car for about 2 to 3 kilometers. So what's your take on that? So I actually have no idea on that. And what do you think?
No. This is an excellent point they have made. I think we should really thank who has asked this question. So the way forward is all these things are recyclable. One of the famous football players in the Brazil team used a jersey which was made out of this recycled plastic material. So this entire plastic material is recyclable. So I think that's a way we do it.
So without wasting much time, we have one more talk to go. I would request Sahil, if you can share your slides and continue.
Sir, is my slide visible?
Yes.
Yeah, full screen mode. You have to make it the full screen mode. Yeah.
Good evening. At the outset, I would like to extend my sincere gratitude to Dr. Bala sir, Dr. Vineet sir, Dr. Velarvan sir, and Dr. Girish sir, my mentor, for giving me the opportunity to present the topic sterile ultrasound gel, a new standard in contact asepsis. So why does sterile gel matter? We use ultrasound during HD catheters, tunnel catheter insertions, PD catheter insertions, kidney biopsies, and during AVF cannulations. We presume them to be in a sterile environment, but are they actually in a sterile environment? The non-sterile gel, when used, even if covered by a probe sheath, they can leak microscopically, or they can pick along the sheath folds, or they can come in contact with sterile gloves or drapes. This can lead to contamination of the sterile field and can lead to introduction of infection into the bloodstream and subsequent bacteremia. So this is a small video that demonstrates how the breach of sterility can happen, how a non-sterile ultrasound gel can actually leak. So we are covering the probe with the probe sheath, and the assistant is putting the non-sterile ultrasound gel. So as we can see, there is a chance that we might accidentally leak the non-sterile gel on the outer surface of the probe cover. Then even if we take all the adequate precautions, there is still a chance that there might be microscopic leak happening along the sheath folds, as evident from this. So similarly, while taking an access, there is a chance that we might inadvertently puncture the probe sheath, and this might lead to leakage of the gel onto the sterile surface area, as evident in this. So now I'll talk about the previous documented outbreaks. So the one outbreak I'll be discussing is was in United States, 10 states, where 119 confirmed cases of Burkholderia stabilis infection was detected due to the use of contaminated non-sterile ultrasound gel of a specific company that was being used for central line insertion and vascular access procedures. So following this, the FDA issued a class 1 recall of that ultrasound gel, and CDC mandated sterile gels to be used for all percutaneous procedures. In the Toronto outbreak in 1992 to 94, more than 20 cases of Burkholderia capacia infection were seen in neonatal ICU, which were traced back to refillable ultrasound gel, which were harboring that infection. This led to a hospital-wide policy change that mandated sterile use ultrasound gel. So the next outbreak I'll be discussing was the European outbreak in Germany in 2008 that was seen in more than 60 patients who underwent transrectal ultrasound guided prostate biopsy. So, the cause of infection was found to be multi-use ultrasound gel. Following this, the European guidelines issued precautionary alert for sterile ultrasound gel use. In Indian studies, multiple Indian studies have documented various infections. The studies arise from different parts of India, including Vellore, Chennai, Chandigarh, and Thiruvananthapuram, that have been traced to contaminated ultrasound gel, with predominantly being gram-negative infections and Burkholderia species. So from these outbreaks, we have learned that non-sterile bulk ultrasound gel, they sustain microbiological life, especially the gram-negative bacilli. The refilling or reusing bottle leads to cross-contamination between the patients. Improper storage encourages microbial growth. And if there is a lack of procedural training or a breach, it can lead to breach of sterile field and infection. So these are the procedures we predominantly nephrologists do. The tunnel catheter insertion requires a full sterile barrier. If there is a breach in this technique, and if we use unsterile gel inadvertently, it can lead to increased chances of infections and endocarditis. Similarly, for kidney biopsy, if there is a compromise, it can lead to perinephric abscess or infection. For PD catheter placements, few nephrologists prefer using ultrasound. So, if there is a breach in sterility, it can lead to exit site infection and PD peritonitis. AV fistula mapping and Dopplers, they are considered low risk procedures, and as such they don't cause much risk, but in frail patients and elderly, they have been associated with increased risk of bacteremia. So what is the clinical consequence of use of unsterile gel? Uh, it can lead to catheter salvage failure. It can lead to infection, sepsis, increased morbidity and mortality, increased hospitalization, increased cost, and increased antibiotic usage and antibiotic resistance. So even the unopened bulk gel bottles, they are not guaranteed sterile. And reusing gel bottles over time increases the bioburden, and the risk of infection is particularly high in ICU patients, diabetics, and dialysis dependent individuals that actually form bulk of our patients. The risk of infection increases with the degree of immunosuppression. With higher degree of immunosuppression, that is in transplant patients and some CKD, there is higher chances of sepsis. More frequent procedures, more interventions, increased chances of infections. Patients with pre-existing central lines, they have higher chances of infection. And those with poor skin integrity, there is higher chances of infections. Global guidelines, the CDC, WHO, and NHS, they all state that for invasive procedure involving ultrasound, sterile single-use gel is mandatory. So these are the various organizations and the recommendations they have given. CDC recommends use of only sterile ultrasound gel for all percutaneous procedures, and the context in which they have given the recommendation is invasive procedures, catheter insertion, and biopsies. FDA mandates sterile gel for use on non-intact skin or mucous membrane, specifically in ICU procedures, surgical site imaging, and biopsies. American Institute of Ultrasound and Medicine recommends sterile single-use gel for procedures involving sterile body sites or mucosa, and they have given the recommendation in context of transvaginal, transrectal, vascular access, and interventional ultrasound. NHS advises strict use of sterile gel for invasive and high-risk procedures in ICU, NICU, dialysis access, central line, and biopsies. WHO also recommends aseptic technique and sterile products in all invasive procedures. Good infection prevention practice recommendation. It recommends use of sterile gel mandatory for invasive procedures, contact with non-intact skin, contact with mucous membrane, that is transrectal or transvaginal procedures, or immunocompromised or NICU or critically ill patients. Whereas it suggests unsterile gel may be used, it does not say mandatorily, it says may be used in low risk setting. That is only general examination on intact skin. Whereas non-intact skin, it mandates use of sterile gel. For use of sterile gel, it should be ensured that these are unopened sachets or containers that are labeled as sterile, and they should be single use, and once they are opened, they should not be reused either with other patient or neither they should be stored. For non-sterile ultrasound gel, they recommend preferable use of pre-filled bottles than use of refilling bottles. They suggest to remove the gel from the skin after the procedure with a clean paper or a towel or a wipe. And the nozzle of the bottle, it should not come in contact with the patient, staff, or instrument. And if by any mistake, if the nozzle comes in contact with the patient's skin, then the bottle should be discarded. Regarding warming of gel, it suggests that warming of gel should be performed by the use of dry heat, and it should be warmed properly. The gel bottle should be kept upright in the warmers and not inverted, as it is seen that it increases the chance of infection if not kept properly. So coming to the Indian scenario, these are the two, to my knowledge, these are the two ultrasound gels that are available that are said to be sterile. But there is one of them is not regulated by appropriate authorities, and problem is that they are very much limited. So we require a Indian recommendation and guidelines to support their use, and there is an unmet need for educating the healthcare professionals for its mandatorily use. So coming to conclusion, sterile gel is not a luxury. It is the standard of care in critical intervention nephrology procedures. The CDC, WHO, and NHS guidelines, they all state that for invasive procedures involving ultrasound, Sterile single-use gel is mandatory. There is a need to educate the healthcare professionals for its mandatory use while performing invasive procedures. Thank you.
Thank you, Dr. Sahil, for this enlightening presentation. I think very few of us were actually aware that there is a sterile gel available, and I am very sure many of the new interventionists may not be aware. And it is good to know about this new entity. In fact, a fairly old entity now. So can I have the comments of Chairperson, sir? Will Irving, sir?
Vinay, I mean,
Yes,
Girish,
sir.
can we create, I mean, home developed sterile small pouches and ETO or something?
No, these are Indian developed sterile ultrasound gel, sir. So actually, thankfully now we have two kind of things available. One is the entire kit. So a probe cover, a sterile ultrasound gel, and the rubber bands that also need to be sterile. So entire kit is delivered, and along with the antiseptic wipes, sir. So the entire thing is delivered as one kit for the imaging guided procedures, or we have just a sterile ultrasound gel available as a sachet. So since it's an Indian made, so it is locally made, and it is completely regulated gel. So definitely it is now available across the country, sir.
What is the cost of one pouch?
Cost, I think as of now, we procure it through tender, sir. So we don't know what is the cost, but I think it's very much like an antibiotic, like an augment in cost. Very, very economical and very viable cost, sir. I think so.
One pouch is enough for mapping and.
Absolutely, sir. Yes, yes, yes. One pouch is enough for vascular mapping procedures, everything. Yeah. So maybe if more and more people start using it, and then we actually assess what is the real quantity that is required, then they could customize, as Vale sir said, instead of 20 ml, we could customize it for 10 ml as well, depending upon the requirement. I think it depends upon the volumes and the number of users who are recommending that, sir. Yeah.
Okay.
So someone has put a very nice comment that many of us actually use xylocaine gel, which is a clear fluid. It may not be a good conductor like a ultrasound gel, but it can somehow match. And
yeah, the problem with the xylocaine is it slips off. You know, and the contents, scientifically, if you see the contents of xylocaine gel and the ultrasound gel, I really got surprised that there is so much of scientific thing that goes behind making a sterile ultrasound gel as well. Because US FDA states it is a medical device. So it is categorized as a device, and there are a lot of protocols that need to be followed before they evolve with a sterile ultrasound gel. So I think and also there is a lot of variation in the strength of the sterile ultrasound gel. Like, if you are using it for the endovascular procedures, the strength is different. If you are using it purely for imaging procedures, the strength is different. And the sterile ultrasound gel is a device for a reason. The composition, the coupling with the probe, all those things also matter. And it's almost like I think Suresh sir will throw more light on this. It's almost like a 3-decade-old medical device in the Western world. Just like interventional nephrology, sterile ultrasound gel is also evolving with our practice. As our practice grows, this device is also going to grow.
Girish, for a quick
Yes, sir.
ultrasound in transplant patients,
Yes.
post-transplant room,
Yes, sir.
what I do is I soak a gauze in betadine.
Yeah, exactly, sir.
And,
yes,
basically, put it
yeah,
over there,
yeah.
and that works also.
Yes, sir. Yes, sir. No, sir. I think, with more and more transplants happening, with more and more invasive imaging procedures happening, like in ICU, we do so many imaging procedures, like, whether it is echo of a transplant patient, or Doppler of a transplant patient, or just basic lung imaging of the transplant patients. I think it makes our life easier to know that we are using something which is sterile. Our time and our stress is also mitigated, because when we use the regular things, we have to be cognizant of each and every step. sometimes we keep using the gloves. What if some breach happens somewhere? We don't want to have any source of infection. So I think having these kind of gadgets mitigates our risk and keeps our life more peaceful.
Not to decrease the importance of the gel sachet.
Yes,
Just
sir.
know from Avail, have you done this using simply
Yes, sir. Sir,
butadiene?
I just keenly observing your statement, sir. Sir, most of the theaters, ultrasound is roaming around the entire hospital, sir. It is handled by many people. The health assistant moving the ultrasound. I think if you are dedicated ultrasound inside, this will this. But I think which cannot be equated with ultrasound gel, sir, for luxury and protection. So I would prefer if it's a dedicated ultrasound inside. Okay, just because for transplant, we just put a probe and see whether the flow is there, a Doppler pattern. Just a few seconds we do it. But we want to do a very comprehensive study sitting near the patient. I think we need to have a good coupling gel with the antiseptic property.
Yeah, right.
We rightly said, I think both have presented so nicely. I think we should think beyond scrubbing. Actually, not only, we scrub ourselves very, very clean, but when we make, we have to think of a site, line, and patient, the entire circuit to be taken into care. Just a breach of one, as you said rightly, one crack will in the shield will produce shattering the entire fortress of our system. So I'm the fascinating presentation by two people.
Unfortunately, sir, like at least in 40 bedded nephrology department, at least you will see 2 to 3 beds with sepsis, which is very much preventable. At least for that sake, we need to up our barriers which are currently available, sir.
I think infection antibiotics is such a big concern. I think it is just a matter of availability and being aware. So I don't think many of us will be averse to using ultrasound gel if it is because if it is helpful. It's a very good thing.
Yeah,
so any comments, R.K. Adab, sir?
Dr. Vinit, thank you. A nice presentation by both the presenters, and congratulations, Dr. Girish, for nice studies. In AIMS, in our institute, IR department, interventional radiology, they are using sterile gel from last, I think, more than 10 years. They have in-house how to sterilize. But in our department, unfortunately, we don't have.
Oh, they make in-house sterilization of the gel?
Yes, sir.
Ma'am, any comments, ma'am? Neelam, ma'am?
It's a good idea. I mean, the single-use pouches or the sachets will do wonder. But then thing is, it's better to have you have the cover, you have the rubber band, and you have a tissue paper along with, so that pick up one, use it, and then throw it, and don't use it on another patient, because this does not have preservatives in it. So once it is open, you cannot use it again. So anything actually which does not have preservating will always allow the bacteria to multiply. So it is better that go ahead with single-use devices rather than going for 20 ml or for a bottle and all. Otherwise, it will become an open system again, and you're using a sterile one or an unsterile one is going to be the same. So better to have single sachet in single packing with the cover, rubber band, and the tissue papers in one go.
And
so that
most
it completes
important,
and closed
yes,
system is there.
yes. But one thing, I would really appreciate Glomcon, who has raised a very, very valid point. Today, global warming and the pollution is a major concern. So I think as strong as we advocate for this sterile ultrasound gel, we also advocate on the safe disposal. Maybe the onus is on us to store and to store all the used sterile ultrasound gels and the probe covers in one place, and ensure that all of them are disposed in a very, very bio-friendly and biodegradable manner. I would extend to the extent of requesting the company who is manufacturing the sterile ultrasound gel or probe cover that they should also consider recycling this in a very, very environmental friendly way. Not only you want to sell the product, but you also want to make sure that this is disposed and degraded in a very, very formal way, so that today global warming is a major concern. So we should also take the onus to dispose it in a better way. That's a fantastic, I think that's the best review I got from Glomcon, whoever it is there.
Why Gloom, Mr. Gloomcon?
Suresh sir, what is your experience of this probe course? Ultrasound gels. Suresh sir.
Okay. So it's some of the things I can. So one is as absolutely we use one-time use. We use it, throw it away. Period. Once you open, it's thrown away. Even the sachets or bottles are coming in small. We throw it away. The important thing is also the probe cover. Probe cover should not be open in both ends. So I saw that lady putting in through this and bringing in, it's open on both ends. So one end of it is closed like your socks, and it's folded in nice such a way that you put your hand in and it is still closed. It'll go up to this. Then you put the probe and then the sterile, you pull it back. So when you do that, there is no leakage of gel or anything outside the probe cover. So the important thing, the probe cover has to be closed. It needs to be like cul-de-sac. It's one-ended. Another thing is with every use of ultrasound, once it's used, it is cleaned. Either a spray gel or a sterile towel is used to, whether it's a for a procedure, endovascular procedure or vein mapping, everything, every time it's used, you have to clean it. Because once you don't clean, the gel sticks onto it and it can harbor infection, especially fungus. So it has to be cleaned. And important thing is you have to use those sterile gels or towels. It does not damage your probe. So if you follow these things, you will have a better success. So for taking care of the probe, especially as Vail Arvind says, these ultrasound walks all over the place. So it is important that you have a dedicated one in the OR and another one outside, but many places don't have the luxury. So it has to be clean, period. Whenever you bring it back to OR, you have to clean it before you bring it in. And when you use it outside, clean it in. I think if you follow these simple things, you can prevent infection to a lot of it. And never bring it open sachets.
Thankfully, for our settings, sir, the Sono kit, whatever is available, they're also giving us with disinfectant and antiseptic wipes also.
Yeah.
So again, that will take care of the probe cleaning also, sir. That's a fantastic thing. So they give us 2 wipes in that kit.
So if it comes with the kit, you won't forget it. You will use it.
Yes,
and
yes.
use it. If it's not there, then you forget it.
Yes, sir. Yeah.
Just you sent some sample to me. I was using it, but
Yeah.
once you just tear open this one end, can you see the pouch here?
Yes, sir.
So this is what the point of the cleavage you have given here. When
Yeah.
I put, I think I'm not able to put it in around as he said, like a cordon of the entire the area. Suppose for a transplant incision, I want to put it, but can you
Okay.
make it with a small, like a toothpaste, like with a simple nozzle?
Yeah.
That is a good.
It can be done, sir. I think in Western world they have toothpaste kind of things also, but I think it boils down to the demand, sir. It's demand and supply.
This application through this pouch is a little difficult, Grace. That's what I found.
Girish, is this pouch inside another sterile thing? Because
Yes, sir. Yes.
One more.
So like
Yeah, I think Vail sir has the thing.
So this is the main cover inside which you can.
Yeah, because I was imagining if you're holding this with your sterile.
No, sir. It comes in a completely sterile packing.
And it comes in this kind of packing, sir.
Yeah.
Okay.
I was
You
using
usually have 2 rubber bands and then
yes, sir. Yes. The Sono kit is also available, sir. The Sono kit is also available. I think this is a regular sterile gel. So sir has the loose sterile gel, but the entire kit is available, sir.
Okay.
Then that reminds me of one thing. Like, see, more than all these innovations, it's the discipline and the etiquette which is more.
Oh, absolutely, sir. There is no substitute for that.
Yeah, because long back, I remember there was a lot of infections in my dialysis room, and I was really worried and wondering what antibiotic I should be giving as a fill solution and all those stuff. Then I came across one article. The title said, this simple procedure or the simple thing has reduced our infection rate in dialysis room by more than 50-60%. That was the title. That time I had no access to that article. This was long ago, 10-15 years ago. Then with great difficulty, I approached libraries, people in big institution, and got that article. And I was very interestedly trying to read that and trying to get some like a new drug or a new chemical or something which is going to prevent my infections in the dialysis room. But it was all about protocols, like, from start to beginning, as the patient comes, each one has to announce, I have done, scrubbing once, twice. That is all recorded. Each and every step is announced and recorded. And that was the simple thing they were doing, and that itself reduced the infection rate. This is just to show that, it is a lack of our following protocols, the known ones and the new ones, which leads to all these maladies.
I think even though all these innovations, they come with a cost, but if you look at the long term, you save money from not getting infections,
That's what, sir.
complications, and all.
Many times, people ask, let us say the sterile ultrasound gel is expensive. The simple explanation is, compare with the course of the basic antibiotic. Let's compare it with augmentin, tablet augmentin. If you give for 5 days, then probably augmentin, I don't know, it comes to close to 300 or 400 rupees. And then the sterile ultrasound gel sachet, I don't think it is more than 150 or 200 rupees. So even with the basic, please don't compare with the non-sterile gel. You should rather compare it with an antibiotic or the cost of the hospitalization. That's the way it should always be looked upon, because it's a device. As Sahil said in this beginning, it is not a luxury, it is a mandatory practice to use.
The other thing what they do here is, I used to get annoyed before, in our vascular center, the nurse manager randomly catches us every few months and asks us to wash the hand. She'll watch us wash the hand. And then after you wash the hand, before you go to a procedure, there's a solution she'll put in your hand and dry it. And then with the light shining on it, the blue light, you can see which part of the hand is not clean. So it improves the practice of how you clean the hand by improving your technique. And the other thing they also do is, many of the hospitals now has, every few months they have this voluntary computer courses you have to do and go through it and take some short tests and get approved for in terms of hand washing and things. So which will keep you, not that we are not doing this properly, but sometimes we, in a hurry, we might lack our fortress might be broken. So it keeps us in the mind that we have to do X, Y, and Z, because all these are protocols, and whether it is stupid or not, we have to every time follow this protocol, because these protocols are made for a reason. And I think that following this protocol every single day, every single time, night or day, is the most important thing in preventing these.
Yeah, well said, well said. Yeah. Right from scrubbing your hands and all those procedures, which is stuck in the wash area in most of the places.
Yeah, exactly. There's a thing stuck there.
How many people follow that?
Yeah, I used to get irritated when a nurse manager does it, because we think we're doctors and why are they testing on us? But it is a complete. So.
Yes.
Anyway, good presentation. It's amazing. I really applaud those two, young fellows presenting.
Yeah, this was because we have been talking about a lot of new procedures and interesting things inside the cath lab and all that. This, this was, this elephant was hidden, and it has been brought to light, and there's a great.
This is very basic, actually, basic and very important.
I think once in a quarter we should have a reminder of our sterile aseptic precautions, sir. As we advance in our techniques, we should not falter on the aseptic precautions.
Very true. Very true. When we break the barrier, we must build even stronger shield, right?
Absolutely, sir. Absolutely. Absolutely.
So we have to raise a shield before the battle, right? So the good awareness created by this two talk, and let's use this gel and find it usefulness, right? As you said, rightly said, the gel can be a part of the ultrasound cost, actually. If you charge 1,000 rupees, you just make it the part mandatory, actually. This to be as a mandatory part of your charging system in the corporate.
No, I think the simplest way to ensure that every patient, let's say tomorrow we have a vascular access clinic or whatever it is, when you issue the OPD paper for the patient, issue an ultrasound gel as well, so that the patient carries the sterile ultrasound gel with himself, and when he's ready to be imaged, he himself gives it to the clinician, so that there is 100% guarantee of the sterile aseptic precautions being followed. You issue a sono kit at the OPD counter itself, so that he's assured of asepsis before he starts the procedure.
Or actually, the other way of when you bring these patients, you give prescriptions, right, to medicines and all that. So many
Yes.
places, hospitals, you give prescription, they have to buy medicines and come. Doctors should give a prescription to get this by the patient, so patient will buy and they don't feel bad that doctors are charging, because they are spending the money directly with some other person and get it as a prescription, so that they don't
Yes.
feel that doctors are minting money. So
Absolutely,
it's
sir.
a
Absolutely.
psychology.
Yes. Yes.
I think, Girish, if you're done with this important thing, we have, if you can spare 3 to 4 minutes for a small case to be discussed. Can I?
Sure, sir.
Yes, sir. Sure, sir.
Can I just to break?
Sure, sir. Sure.
You know. Anish, the fellow who is with me, will present a very short case, 3-4
Yes,
minutes.
sir. Yes.
Yes, Anish.
Hello, am I audible, sir?
Yeah.
Yeah.
Yeah. Good evening, everyone. I'll just present a very short case. This is about a 45-year-old male who is a known case of chronic kidney disease on maintenance hemodialysis since the last 1.5 years. So initially, he was on dialysis through a left RC fistula, which led on to left subclavian vein stenosis, for which angioplasty had been done thrice in the last 1 year. Consequently, he developed complete occlusion of the left subclavian vein, and a right IJV non-tunnel hemodialysis catheter was placed as a temporary measure before an alternate access. By 10 day, a nurse noted that there is a leakage of blood from the arterial extension limb of the hemodialysis catheter. With flow issues, he was taken up for a catheter exchange over the guide wire. After the exchange, there was inability to aspirate blood from the arterial extension limb. Inflow was normal. So a contrast study was done, and this is a fluoroscopic image of the contrast study. So we can see that there is a clot in one of the limbs, and we pushed 10 ml of iohexol, and this is the video.
You see good flow, into the downwards. So we were surprised what was causing the dysfunction. Yeah. So then, on careful look at the video. Oh, where is that? No, actually, this was a fibrin sheath. It was, you see trickling coming out here from there. Yeah. So that gave us the clue, and we knew it was a fibrin sheath. And we exchanged, we had to maneuver it instead of pulling out the whole thing. We drew a line on the superior extension of the fibrin sheath and drew out the thing and reintroduce the catheter from that line, then put in a guide wire, and then we again repushed the catheter and it started functioning. So this is just to amazing how quickly sheets can develop. So we always think of fibrin sheets in quite old catheters, especially tunnel catheters, after significant number of days pass. But this shows in 10 days, 10 to 12 days, how sheets can develop even in temporary catheters. Just to highlight this and to get from the audience how have they seen such early fibrin sheets. But mostly we don't look for fibrin sheets in temporary catheters, and this early we don't think of it either. So any comments?
Can I have a comment, Bala?
Yes.
So this is Damodar Kumbala from US.
Yes.
Yeah, I've seen in 24 to 48 hours.
Oh.
So my experience, I used in this scenario drug-coated balloons. So, some of the patients like in US, like they're on 20, 21-year-olds on dialysis for 40, 20 some years. So any case, some of them are like catheter dependent, all accesses are exhausted. So they tend to form within 24 to 48 hours. I have not published a paper yet, but drug-coated balloons, if you have a patient catheter dependent, he gets recurrent fibrin sheath. The only way is to you do a balloon angioplasty or use a Fogarty to strip it. But if they come back very aggressively, DCBs have a role. It's my own experience, and they tend not to form within short interval of time.
So actually, Sampath and me, we were thinking of a small study where, why not put in contrast and check whenever you try to remove a temporary.
Yeah. So
And
any catheter, that's the standard protocol we do. Like, there are three things for non-infectious etiology why the catheter has a malfunction. Either a thrombus or a fibrin sheath. Most of the times, fibrin sheath can form from all the way from exit site into the right atrium. So even if you don't see it, you have to pull the catheter all the way back up to the IJ and push the dye so that you can see forming a sheath. And then, the best way is to do a balloon angioplasty, which can take it out completely.
yeah, see, this is the one which gave the clue. Actually, we were perplexed for some time because
Right.
there's good flow downwards and this small trickle, gave
Right. Sometimes you'll see nice sheath. I think you guys did a good angiography on it, but sometimes it's very tricky. Unless you pull it all the way up, you may not able to appreciate it very clearly. That's
So
all
what
for me.
brand of the
Thank you.
catheter you used?
Mahir-
Bala
Pardon?
sir?
It was
No, Bala sir, what brand you used? One of the approved brands or the local brands?
Mahirkar catheter.
So that is a good brand. So it should not be material.
Yes.
Should not be there.
See, I don't think the brand matters. Fibrin sheath, it depends. So like if you see an very old, frail patient, many of them don't get fibrin sheath. It is something
Right.
to do with how your body reacts. And all the fibrin sheath starts from the venotomy site and goes down. And as I said, I've seen within 48 hours for tunnel catheter. I don't have much experience with temporary catheters because we hardly use temporary catheters as much we avoid. So we see this. And what I do is few things I do. When you strip the fibrin sheath, I use bigger balloons because that will, when you use smaller balloons, it won't degrade. So you use a big balloon which accommodates the size of your vessel, whatever it is. Number one. Number two, the newer catheters have got good success on it, which, the palindrome catheter, Tal palindrome, who made a palindrome catheter. Now you have the white tip catheter.